applied anatomy of eyelid and the face cue scoring system. Change नहीं हो रहा. Now eyelid, it's a complex specialized facial adaptation which functions as to protect, moisten and clean the ocular surface, and it is intricately connected to the facial anatomy, the lacrimal system and the orbit. A brief talk about the topography. The eyelids cover the upper and lower parts of the eyeball, and the vertical palpebral fissure height is about 10 to 11 millimeter, and the horizontal palpebral fissure height from the medial to the lateral canthus is about 28 to 30 millimeter. The lateral canthus lies at a level of 2 to 4 millimeter above the medial canthus, and the vertical lid crease in the upper eyelid is about 8 to 11 millimeters. Now, few abnormalities of topography. Blepharotosis is if the vertical lid height or the margin reflex distance is decreased, and the upper eyelid, there is drooping of the upper eyelid. Blepharophimosis is a condition where there is shortening of the horizontal palpebral fissure. If there is increase of the horizontal palpebral fissure with increase in the pars lacrimalis and the pars ciliaris, and there is lateral ectropenia in the upper and lower eyelid, it is known as euryblepharon. Whereas if there is an increased lid fold in the lower eyelid, it is known as epiblepharon. Now, as we can see that the upper and the lower eyelids are similar in anatomy, and from anterior to posterior the structures are skin, subcutaneous fat tissue, then a layer of striated muscle, that is the orbicularis, then the layer of levator, then tarsus, orbital septum, Mueller's muscle and conjunctiva. Eyelid skin, it extends from below the eyebrow superiorly to the cheek. It is the thinnest skin in the body, and it is highly stretchable, and also it has very thin subcutaneous tissue. So it has faster healing and minimal scarring, but since it is highly stretchable, eyelid edema can stretch it up to 3 times, and also there might be permanent stretch leading to blepharochalasis and dermatochalasis. And most importantly, skin, this type of skin is not found in anywhere in the body, and there is difficulty in skin grafting. We can try medial arm skin or the supraclavicular skin, but like for like match is difficult. Now, eyelid margin, it can be divided into the pars lacrimalis, which is medial to the punctum, and pars palpebralis, which is lateral to the punctum. Pars lacrimalis is rounded margin, and pars palpebralis is square-edged margin. The specialized structure in the eyelid margin is the eyelashes, which are specialized hair follicles. The eyelashes point up and out in the upper lid and down and out in the lower lids. They are highly innervated and sensitive, and the follicles of the eyelashes are 1.4 to 2.4 millimeter deep, and we should keep this in mind while performing electrolysis. There might be lash ptosis, which indicates a suboptimal orbicularis and rhyolin muscle support, and the condition known as cilia incarnata is the lash growth from above the eyelid margin. Here we can see a cilia crescere internum. There might be also an externum variant. The other structures of the eyelid margin from anterior to posterior are the anterior eyelid margin, then the gray line, which is formed by the insertion of the rhyolin muscles, then the meibomian gland orifices, the mucocutaneous junction, the marginal conjunctiva, and the posterior eyelid margin. The marginal conjunctiva extends up to the epitarsal border. Now, the orbicularis, it is the chief striated muscle of the eyelids. It is part of the superficial muscular plane, and it is connected to the eyelid skin by fibrous septa. It originates from the nasal part of the frontal, the maxilla in front of the lacrimal crest, and the anterior surface and borders of the medial palpebral ligament. It has various parts, and the orbital portion is supplied by the temporal branch of the facial nerve, and the zygomatic branch of the facial nerve supplies the palpebral part, the preseptal and the pretarsal. Here we can see that the different parts, already I have mentioned. The pretarsal part is further subdivided into superficial and deep. The deep is also known as the Horner-Duvernay muscle. And the other specialized modifications, the pars ciliaris as the muscle of rhyolin, the pars subtalaris, that the Claude's muscle, and the pars fascicularis, the Lifham's muscle. This is responsible for the direction of the eyelashes. I'll not go into details of the individual parts because I'm running out of time. Now, here is a diagram of the preseptal head of the orbicularis oculi, the superficial and the deep head, which is originating from the medial canthal ligament, and they are the canaliculi are included within the of the preseptal fibers. The orbital part, it originates from the frontal process of the maxilla, and fibers pass around the orbital rim in a concentric fashion, and without any delay, it inserts just inferior to the origin after concentric arrangement around the eyelid margin. So orbicularis is actually a sphincter muscle. It has dual blood supply from both the external carotid and the internal carotid system. And the functions are involuntary blinking, which is caused by the preseptal and the pretarsal components, and forced closure by the orbital and the preseptal components, and lacrimal pump by the Horner's muscle, which is the deep component of the preseptal fibers, and lipid pump, that is from the meibomian gland orifices, is by the pretarsal and most commonly the Rylan muscles. Now, medial canthal ligament, it is one of the structures of the eyelid skeleton which connects the tarsus to the bone, and it is anteriorly attached to the anterior lacrimal crest and superiorly along the frontal process of maxilla and the frontal bone. The deep part, which is important, passes along the lacrimal fascia to insert on the posterior lacrimal crest. Here is a diagram of the same of the medial canthal ligament, the tarsus and the lateral canthal ligament, which forms the eyelid skeleton. And the lateral canthal ligament is the fibrous lateral tarsal terminations. It has two crura and it inserts at the Whitnell's lateral tubercle. It is also connected to the lateral rectus check ligament and is attached to the orbital septum, the lateral horn of the levator, the lacrimal gland fascia, and the Lockwood's ligament. Here's a clinical implication is that in case, since the lateral rectus is connected to the tarsus, if we have to decrease pressure on the globe in case of retrobulbar hemorrhage, not only we have to perform a lateral canthotomy, we also have to perform lateral cantholysis of the respective eyelid to release the crura and mobilize the eyelid. Now, orbital septum is a thin fibrous membrane delineating the anterior boundary of the orbit. It arises from the superior orbital margin, also known as the arcus marginalis. Medially, it is adherent to the anterior lacrimal fascia and then inserts to the medial canthal ligament. Laterally, it inserts to the lateral canthal ligament and to the Whitnell's tubercle. Now, we can see that the orbital septum separates the anterior lid and from the orbit and causes a demarcation so that no structure can pass through except for a few neurovascular bundles. This will be important as any preseptal cellulitis is usually contained within this space. Now, pre-aponeurotic fat pads, they are extensions of the extraconal fat, limited by the anterior septum. Thus, any weak or dehiscent septum, as might be happening in trauma or old age, will cause the fat prolapse, and it is a surgical landmark. The upper lid pre-aponeurotic fat has the central fat pad and the nasal fat pad. Now, the nasal fat pad is from a different neuroectodermal origin and is a yellowish in color and has larger globules. And in the lower eyelid, there are three fat pads, the medial, central, and the lateral fat pads. And here we have to remember that the inferior oblique muscle and its arcuate expansion should not be injured while we are performing any cosmetic procedures to the fat pads. Now, the most important muscle for the eyelid, the levator palpebrae superioris, it originates from the lesser wing of the sphenoid above the annulus of Zinn and superolateral to the optic canal, as we can see in this diagram. It is 4 mm in origin, 8 mm in the mid-orbit, and gradually fans outwards. It is 36 mm in length, divided between aponeurosis and the muscle, 1/3 and 2/3 respectively. Here we can see a diagram of the fan-shaped arrangement of the levator, the muscle, and the termination into the aponeurosis. It also has a conjoint fascial sheath, which is present in the anterior 1/3 of levator, posterior to the Whitnell's ligament. This fascial sheath envelopes the levator, the superior rectus, and also inserts into the fornicial suspensory ligaments. This results in a coordinated movement of the superior rectus, levator, and the superior fornix as a complex. That is, if we look upwards, there is deepening of the fornix. Also, this causes, if there is supramaximal resection of the levator, there might be fornix prolapse. So we have to keep that in mind. Now, the Whitnell's ligament, it is a condensation of the fascial sheath around the levator, seen as a prominent white line. It has two parts, the superior transverse ligament and the posterior layer. The transverse ligament presents as a triangular fashion and the posterior layer as a flat ligament. It functions as a check ligament, that the levator is transverse from the muscle to the aponeurotic part, though this might be controversial. It also might act as a pulley and a pivot to change of the vector of the levator action from the horizontal to the vertical vector. Here we can see the Whitnell's ligament, and this is the levator muscle and the levator aponeurosis, and the Whitnell's ligament is connected to the orbital rim. Now, there are two horns of the levator, the lateral horn and the medial horn. The lateral horn is stronger and it divides the lacrimal gland into the orbital and the palpebral lobe, then slips to the lateral rectus and fuses with the capsulopalpebral fascia of the lower lid and inserts into the lateral tubercle. And the medial horn is weaker and it blends with the orbital septum and inserts to the medial canthal ligament and posterior lacrimal crest. This distributes the forces to the medial and lateral component and causes stability of the upper eyelid and keeps the eyelid opposed to the cornea. And the aponeurosis, it might be single layer in Caucasians or may split into the anterior and posterior in Asians. It inserts 3 to 4 millimeter below the upper edge of the tarsus and also sends slips to the orbicularis and attaches to the skin to form the upper lid crease. Thus, the 5 insertions of the levator at the upper fornix, the medial horn inserts to the medial canthal ligament and lacrimal crest, the lateral horn inserts to the lateral tubercle, the skin inserts to form, the skin insertion causes the eyelid crease, and the tarsus, the insertion to the tarsus forms the upper edge in the upper edge and the anterior surface. Now, when we remove the levator, we can find the Muller's muscle, which is present deep to it. It is a smooth muscle which originates from the undersurface of the levator anterior to the vitals. It interdigitates with the levator and runs downwards posterior to it and inserts at the anterior superior tarsal border. Some have hypothesized that this might be a continuation of the levator muscle itself. There are various theories about its function. That Haramoto's tarsal suspension theory say that Muller's muscle is actually responsible for the suspension of the tarsus and levator is responsible for the skin and the eyelid. And the Horner syndrome is the sympathetic innervation to the Muller's muscle comes from the paravertebral sympathetic chain, and this is hampered in Horner syndrome, and it functions to cause sustained eyelid elevation after levator lifts it. Now, analogous to the levator is the lower lid retractor, which is the capsulopalpebral fascia. It arises from the inferior rectus, the Lockwood's ligament and capsule of the inferior rectus and inferior oblique. Then it fuses with the orbital septum below the tarsus. There is also conjoint insertion to the lower border of the tarsus and slips to the inferior fornix and skin. As we can see in this diagram, the capsulopalpebral fascia, it divides and inserts into the tarsus and the inferior fornix and also gives slips to the skin. Similar to the levator, dehiscent capsulopalpebral fascia causes higher position of the lower lid and shallow inferior fornix, and there might be lower lid retraction in inferior rectus recession. The tarsus is a part of the skeleton of the eyelids. It's a dense fibrous tissue, and it has 20 to 25 meibomian glands in each lid, as we know. And dystichiasis is caused by the regressive metaplasia of the specialized sebaceous gland back to a pilosebaceous unit. I'll not go into the sensory innervation. There are nerves from the lateral to the medial in this diagram, and also the motor innervation. We are running out of time. Now, the vascular supply, you have to keep in mind that in the upper eyelid there is a superior marginal arcade and is a superior peripheral arcade, and these are interconnected between the orbicularis and the tarsus, and this plane should not be disturbed during any upper eyelid surgery, as this will cause torrential bleeding and we have to cauterize all the vessels. But we have to, there is extensive anastomosis between the external carotid system and the internal carotid system in the eyelids, and this causes the excellent wound healing, and also because there is so much good blood supply, that the flaps also have good blood supply, and there is good uptake of the flaps in any surgery of the eyelids. In the venous drainage, we have to remember the angular vein, which is formed by the supraorbital vein and the supratrochlear vein. And here we can see that the angular vein actually lies in front of the anterior lacrimal crest, so that in case of DCR surgery, if we are limited to our actual incision along the orbital rim of the anterior lacrimal crest, we should not actually damage the angular vein. That will cause bleeding. The lymphatics on the outer canthus, the lymph vessels goes to the preauricular lymph nodes, and the inner canthus goes to the submandibular lymph nodes. Now, a little bit about the face scoring. This is the most important tool in the recent times for the facial aesthetic surgeon and the oculoplastic surgeon, as it is a patient reported outcome measure, and it measures 3 domains: the facial appearance, the health related quality of life, and the adverse effects. This is reported by the patients, and each domain includes multiple scales or checklists. This is a framework about how there is qualitative and quantitative research for the FaceQ conceptual framework, and there are a series of items, and a patient is asked to respond on a 4-point scale, and answers are summed up to convert to a score of 0 to 100. For most of the scales, a higher score indicates a better outcome. There is no total score, only scores of the individual functioning scale. Here is the actual FaceQ scoring system, and I'll be happy to give the details of the FaceQ scoring system, but I'll not go into here. Thank you all.